So medical coding scenarios involve translating patient diagnosis, treatments, procedures into standardized codes for accurate billing and reimbursement. Coding differs between emergency, inpatient, outpatient, specialty cases requiring knowledge of ICD, CPT, and HCPCS guidelines. Accurate coding depends on detailed physician documentation, ensuring correct code assignment and minimizing claim denials. So we have already spoken about medical coding. So what is medical coding exactly? You have a medical record in front of you. How is that medical record created? It is the interaction between the patient and the doctor. So whenever you go to a doctor, you tell the doctor what are symptoms you are having, what all discomfort you are having, or what all fears, anxiety, all your complaints you tell to the doctor. The doctor notes those complaints. He also himself checks on you, takes the vitals, does general examination to understand more about your illness, right? So whatever interaction this is happening between the patient and the doctor, all this is documented. Okay. So physician sees n number of patients in a day. So if the patient is coming after 3 months, 6 months, or even after 1 week, the physician will not remember each and every detail about the patient. So when the things are documented, it becomes easier for the physician also to remember everything, and also for the patient to understand that whatever the patient has told, it has been understood correctly by the physician, right? So from clinical point of view, this medical document is created, but this medical document does not just stay for a clinical use. This document is used for the reimbursement cycles. What is reimbursement cycle basically? So patients don't pay upfront to the physician. It is done to the insurance company. So this medical document which is created, it goes to the medical coding person. The medical coding person, they select the codes, select the appropriate codes, and these codes then go to the medical billing department who give the appropriate uh, monetary value to it. And finally, they submit the claim to the insurance company, and the insurance company does the final reimbursement to the physician. So this document which is created has to be accurate. If there is any information missing is in this document, the medical coder will not be able to select the code, and likewise, the insurance company will not be able to do the reimbursement. So this is the whole medical review cycle that is happening, and medical coding is the important transition phase between the medical document and the insurance companies. So this translation has to be very accurate. Okay, so it is not just the diagnosis which is done into coding, even the treatments, procedures, or any durables which are given to the patient, or any other rehabilitation equipment which is given to the patient, even those are taken into codes. Okay, so that's the reason why we have ICD code, CPT code, and HCPCS codes. We have already discussed the different codes in detail. What do they refer to? Now again, the patient doesn't always come in the OPD. OPD is outpatient. Okay, the patient always doesn't come in like for a follow-up or just a physician in the clinic, right? The patient might come in the hospital for a surgery or for an emergency. Okay, the patient might go to a specialist doctor. Okay, so different scenarios are there where a patient is seen. Okay, so that's the reason why coding is also not just specifically only for outpatient. It can be for any medical scenario which is present. It can be for emergency, it can be for home health services, it can be for inpatient services, it can be for any other specialty case. Okay, so whatever it be, you have to select the appropriate. So whatever scenario the patient is coming into, your main aim is to understand the physician document whatever document is created, and likewise select the correct and accurate. If there is any mistake in selection of codes, it will affect the further reimbursement cycle. It will affect the billing. It will also affect the reimbursement to the physician. No distinction made between new and established patients in emergency department. So ED basically is an emergency department. So when a patient is coming into an emergency department, you don't see whether the patient has come for the first time or is a regular patient. You see what is the criticality for which the patient is coming into emergency, right? Nobody goes to an emergency for coughing. Right? There is some really life-threatening situation. That's the reason why the patient is coming to the ED, right? So in a life-threatening situation, you're not going to understand whether the patient is a regular patient or a new patient, right? So there is nothing like that. But if the patient comes in the OPD, over there, we do see whether the patient is a regular patient or a new patient. Okay. So emergency department is defined as an organized hospital-based facility for the provision of unscheduled episodic services to patients who present for immediate medical attention. The facility must be available 24 hours a day. So an ED is always open. Anytime, whether it is day or night, you can go to an emergency department with your problem. Right? Over there, there is no restriction because why is it the word itself says emergency? Okay, there is something life-threatening happening to the patient. It can be an accident, it can be some cardiac dysfunction. Okay, so anything which is life-threatening, that's the reason why a person is rushing to an emergency department, right? So any episodic, it's not an everyday thing, it's a once in a while thing, right? So it's an episodic service given to the patient and it is unscheduled. You don't have to take an appointment. You don't take an appointment to go to the emergency department. Okay, you just go to the emergency department. Now, when somebody comes to an emergency department, so still, when I talk about emergency department, there are certain ways of approach. Okay. So we have evaluation and management, that is EM. So level. So when I take in history, okay. So history is also has to be brief. Okay. That is what we call an HPI. HPI is history of presenting illness. Okay. So you see there are different codes representing different scenarios. Okay. So first we'll just go through the scenarios. Okay. So here history components are there. So different history components are there. HPI, history of presenting illness. ROS, review of systems. Okay. And PFSH, family social history. Okay. So all this is there. And physical exam, that you exam. Whenever the patient comes to the clinic, the doctor himself does some examination. Okay, so that is your physical exam. So we have the subjective component as well as the objective component. So history components, whatever are there, that is the subjective components, and objective components are the physical exams. Okay, so what is the level? A level can be problem focused, expanded problem focus, expanded problem detailed or comprehensive. Okay, so whenever a patient is coming into an emergency, you can never say that the patient is always fully conscious to tell everything about the history. Okay, patient may be semi-conscious, patient may be unconscious, or patient may be fully conscious to tell all the details about the problem. Okay, so emergency department is not just limited to patients who are unconscious or semi-conscious. Even regular patients can come to emergency department, but there has to be something which is concerning about the patient. Okay. Or you can say that immediate attention is required. So depending on what kind of history is taken, you have different level of codes which are there. That is 99281, 99282, 283, 284, and 285. Okay. So you can see if I take the first one, 99281, the HPI is brief, 123, okay, and there is no ROS. There is no particular system that it needs to be reviewed. Okay, limited exam of the affected area. Okay, so the symptoms are very brief. Okay, so you can say the patient had an fracture. Okay, so fracture of hand. Okay, or right arm you can say. Okay, so it's a very limited area. Rest, there is no other problem. Okay, patient had a fall, patient had a fracture, so there is only a particular area which is affected. Only a brief history required, where the patient fell and how it fell and what is the symptom, any pain, swelling, bleeding, anything, nothing. Okay, so it's very problem focused level. Okay, the second scenario you can see, again history is brief but ROS pertinent to at least one. Okay, so you can see severe abdominal pain. Okay, so here one system is only tackled, that is abdomen. Okay, so physical exam again limited to a specific system. Okay, other symptomatic or related symptom areas. Okay, so this is expanded problem and focused. Okay, so here we are focusing on gastrointestinal area itself, but if required we can just do other examinations also. Okay, so like that we can have different levels of history and exam. Okay, so the historical components are there, the physical exams are there, so you can understand if it is limited focused or it is expanded and focused. Okay, if I see 99284, it is extended, so it's 4 plus. Here ROS is also more than one system is involved. Okay, physical exam extended exam of affected area and other symptom, and level is detailed. Okay, so here the patient might be able to tell a lot about the problems it might be having. Okay, like for example, patient has a severe UTI. Okay, urinary tract infection. Okay, patient has bleeding from the uh, urine. Patient is having severe lower abdominal pain. Along with that, patient is also having vomiting, nausea, and fever. Okay, so this can be a detailed examination. Okay, and more than one system is affected. Okay, you'll do a general examination, vitals also you'll check. You will check the urinary system also. You will check the abdominal area also. Okay, so like that. And in extended 99285, it is complete. So the whole most of the systems you're checking in the arteries. Like patient has a brain hemorrhage. Okay, in that you're checking each and every system. Okay, where the other systems are also involved. If there is an episode of sepsis. Okay, so here more than one system you are understanding, or like if patient is having Parkinson's or something like that. Okay, so where a possibility of more than one system, or all the systems to get involved. Okay, so that is a comprehensive level of history and exam. Okay, so this way when you are taking the emergency codes also, it is not always simple and it's not always complicated also. You need to understand what is written in the history to understand what is to be selected in the code. Inpatient, when the patient is admitted in the hospital for more than 24 hours for any reason. Okay, so here you can use both ICD-10 CM as well as ICD-10 PCS for procedures. Okay, because ICD-10 PCS is specifically for procedure coding. Okay, ICD procedural coding. Okay, and it is specifically for inpatient coding. So you can use both ICD-10 for diagnosis and ICD-10 PCS for procedures. Here, when we talk about inpatient, you have to capture the principal diagnosis and the secondary diagnosis. What is the principal diagnosis? Principal diagnosis is the reason why the patient is admitted in the hospital. Okay, patient is having, the patient has a, now there is a difference between primary diagnosis and principal diagnosis. Now patient is having a long standing history of diabetes. Okay, now the patient has also developed arthritis. Okay, so in when the patient is coming in the OPD regular follow-ups, okay, then in that scenario I'm going to say that patient's primary diagnosis is diabetes mellitus and secondary diagnosis is arthritis. Okay, but when I talk about inpatient, now supposing the same patient has diabetes long standing, okay, chronic diabetes the patient is having, but today the patient has been admitted in the hospital with very high blood sugars. Okay, so hyperglycemia. Okay, so here the principal diagnosis will not be diabetes mellitus, but it will be either, or you can say patient is having very high sugars with diabetic ketoacidosis. Okay, so in this, when I talk about principal diagnosis, it will not be diabetes mellitus per se, it will be diabetic ketoacidosis or hyperglycemia. Okay, because that is the reason why the patient got admitted. Otherwise the patient is having diabetes since 10 years, but since 10 years the patient is not there in the hospital. Right, patient came to the hospital when there was some emergency or requirement of the hospital admission. So that becomes your principal diagnosis, and with that principal diagnosis any other problem that the patient is having becomes additional diagnosis or secondary conditions. Okay, so principal diagnosis is the main thing that you need to capture when you're talking about ICD codes in inpatient. Okay, because that also your selection of principal diagnosis is going to greatly affect the coding, okay, the reimbursement, also the DRG. Okay, so what is a DRG? DRG is diagnosis related group. Okay, so what is there in the so diagnosis related group is a certain diagnosis, you're taking it together. Okay, so like you have a basket full of different colored balls. Okay, 4 colored balls: red, blue, green, yellow. So here you are segregating the blue ones in the blue box, red ones in the red box, yellow in the yellow box, and green in the green box. Okay, so this is what a DRG is. So in a hospital, you can have n number of principal diagnoses. So you are clubbing the same diagnosis together. Okay, so here when I'm clubbing the same diagnosis together, what I'm going to look into, I'm going to look into the principal diagnosis. I'm not going to look into the secondary diagnosis. Okay, so principal diagnosis, selection of the principal diagnosis, if it's not proper, is going to also affect the DRG. Okay, and of course, it's definitely going to affect the reimbursement. Okay, so this is the main thing about the encoding, inpatient coding. Outpatient coding, you have to not that complicated, but you need to understand that what is the diagnosis, what are the different procedures that you need to take. So outpatient coding will include physician offices, that is your private clinics. Okay, the OPDs are there in the hospitals also, that is also included, and ambulatory care is also included. So difference between outpatient coding and inpatient coding, ICD-10 CM for diagnosis. Both in both inpatient also and outpatient also, you select ICD-10 CM for diagnosis. But in inpatient, you can select ICD-10 PCS for procedures also. Inpatient, uh, inpatient coding facility coding for probable suspected rule out conditions is allowed. Okay, why? Because sometimes the patient is admitted for some symptoms, but even after certain test or evaluation, still the correct diagnosis is not been able to reach out. Okay, and you cannot keep the patient for a very long time in the hospital, right? So that's the reason why the probable suspected or rule out conditions are allowed. But in outpatient, you cannot have probable suspected or rule out conditions. Okay, because there you can have the symptoms. Now when I talk about, now the patient is coming with certain symptoms, okay, and I need to select the diagnosis. Okay, so what I'll do, I'll select some test to find out what is the diagnosis. Okay, so till then, till the diagnosis is not reached out, I can select the symptoms as the codes. In outpatient, you have CPT and HCPCS level. In inpatient, you have the ICD-10 PCS. Reimbursement primarily based on physician fee, insurance, contact rates, ambulatory surgery center rates, etc., which is there in outpatient. And inpatient, reimbursement is basically based on DRGs. I've already spoken about DRG. Outpatient does not require hospital stay. Inpatient requires an hospital stay. Okay, usually with a 2-day minimum. Outpatient code assignment is based on the encounter or visit. Okay, because here the patient, when we talk about encounter is nothing but the scheduled appointment of a patient with the physician. Okay, that is what is we call as an encounter. Okay, so the physician has seen the patient. Okay, now when we talk about outpatient, the encounter can be 15 minutes, can be 30 minutes, can be 45 minutes, depending on the number of symptoms the patient is having. Secondly, if the patient is a new patient or a follow-up. If the patient is a follow-up, the encounter is less time. But if it's a new patient, because there is a detailed history taken, the encounter timing is increased. Okay, so that also is calculated when we talk about outpatient coding. Okay, in inpatient, what you are going to see, the admission stay, how many days the patient was admitted in the hospital. Okay, services are built on CMS 1500 form, and inpatient, the services are built in UB04 form. So UB04 is actually for submission of claims in the hospital setups. Okay, and this CM 1500 is a form through which you submit the claim in the insurance companies. Okay, so outpatient, you have the CMS 1500, and inpatient, you have the claim submission as UB 400. Now, when we talk about ambulatory care, what all comes in the ambulatory care? Urgent care centers, that is, you're transporting from one place to another or one hospital to other. Specialized care centers. So the patient is not always, cannot be kept always for a long time in a hospital. So certain period the patient is there in the hospital. After that, the patient still requires some assistance. So you can have the specialized care centers where the patient can be put. Ambulatory surgery centers. Okay, and outpatient clinics. Okay, so these are all your ambulatory care. Specialty coding, you are going to a specialist. Okay, now when we go to a doctor, we have a GP. We go over here to a GP, right? In US, we have the primary care physicians, that is PCP. Okay, so those are general. So in general OPD, you go to general doctor. But after that, if you require some specialized care in certain system, you go to that specialist. Okay, you can go to a cardiologist, you can go to an orthopedic radiologist, or you can go to a pediatrician. Okay, so that is your specialty coding. Gastroenterology is also. Okay, so over there we need to, so over there the system is more defined because you're dealing with only one system. Okay, so you are more well aware of the codes, everyday codes which will be dealt. Okay, so if you are there in cardiology, you know you will have to have ECG codes regularly. Okay, catheterization, stress. Okay, other things which are related to cardiology. If I go to a orthopedic, I know it will be more of, fracture or surgeries, or ambulatory, problems with joints, or injections are also very common in orthopedics. If I talk about radiology, I will be talking about imaging processes, um, whether a contrast is used or not used, or a 3D images there, or 2D images there. So different aspects are there. In each specialization, again, we can have different aspects which we come about. But when we talk about specializations, I know that I'm not going to look for all the codes. I know I'm going to look these only these uh, specific codes only. Okay, so that is the specialty codes. Let's talk about some scenarios. A patient arrives in emergency room with chest pain. The physician performs an EKG, orders a troponin test, and documents possible acute myocardial infarction. How this should be coded. So when a patient is coming to a emergency department with when a patient is coming in the emergency department with chest pain, the first thing what the physician will say is to do an EKG. Okay, EKG is nothing but ECG. After that, there will be some blood test that will be required. That is the first that is required is troponin test. Okay, if there is the physician feels that the possibility of myocardial infarct, okay, then this test is required. Okay, so the ICD code will be R07.9, chest pain unspecified, because right now there is no diagnosis which is proved that myocardial infarction is there. Okay, it is just that the patient is come with a chest pain. So that is what the ICD code that will be taken. Procedures. What all procedures you did? First, you did the EKG. So CPT 93010. And another procedure, what you did is troponin test 84484. Okay. So this is how. Only these two tests were done. And what is the symptom? Chest pain. Okay. Possible acute myocardial infarction. It has not been proved as yet until we get the test. Okay. So this is how you do it. So that's all about your coding scenarios. You need to understand what is the document saying, specifically understand what are the different diagnoses. Also understand where is this patient sick, in the emergency department, in the IPD, OPD, okay? And then after that, you need to understand if it's in OPD, what is the time duration taken. Even that is to be taken into consideration, because evaluation management codes require the time also. There is a code, there are specifications for time also. Okay, in inpatient you don't require that. And then you need to decide what all history is there, and likewise you need to select the ICD, CPT, and HCPCS codes. Okay, so this is in brief understanding that first you need to understand from where is the patient coming, okay, ambulatory care or OPD or IPD or emergency department. Then accordingly you see the history, whatever is mentioned. If it is an IPD, you need to make sure that you select the correct principal diagnosis. If you don't know whether the patient is coming from the IPD or OPD, you will not select the principal diagnosis. Okay. So that is very important to understand from where the patient is coming. If it's in the OPD, it's very mandatory to understand how much time the encounter was taken into. Okay. In emergency department, you don't really have to see how much time is taken or whether the patient is a new case or a follow-up. You just need to understand what is the severity of the problem. Okay. And how much history is taken and how much examination. Okay, so that all you need to understand in the emergency. So knowing the source is very important when you talk about the medical coding scenarios. After you understand the source, then the next steps are to be followed according to what is the source. If it's OPD, you should know what all to see. IPD, you should know what all to see. In if emergency department, you need to know what all to see. And then only you're going to be able to select the right codes and the claim can be submitted in the right possible way without getting a denial. Okay. So that's all for today.